as we kind of go through this. So yeah, my name's Andi Orlowski. I'm a health economist and a director of the imaginatively named Health Economics Unit. That's the NHS for you. I'm a lecturer at Imperial. I'm also a PhD student in population health management. I advise NHS England on pop health management. I also advise the World Bank on population health management. There's a theme here. I'm also the president for charity and of the Association of Professional Healthcare Analysts and the vice chair of the HFMA. I'm a massive fucking nerd. Yeah, and normally this is the bit where I apologise, but not tonight, because I'm home. I'm with you guys. Rather than NHS bosses who are looking down their noses at me, fuck you, get it. So I'm glad. So we'll go through it today. We'll talk about how the NHS can learn from the FBI's Most Wanted, and I promise this isn't the wonderful Simon, this isn't a fucking setup. There is a thing. The FBI does have, or one of the FBI's Most Wanted does have a significant role to play in clearly Louise's work that I've stolen for my PhD. This is the one wordy slide. It's from NHS England. I apologise, but I'll try and précis all of it. So we've done this thing called pop health management. We stole it from the Americans. They had accountable care organisations. We stole that because we wanted to use it. We were sued. So we changed the name from accountable care organisations to accountable care systems. Then we were sued again. So we changed the name again to accountable care organisation. No, integrated care organisations. We were sued and then we changed it to integrated care systems. Then they stopped because they were fucking bored. We were all fucking bored. And so, but population health management was the key to this, and the reason being that if you're an evil insurance company and you're not squeezing enough fucking profit from people, what do? You have to find it elsewhere. So what do? We find these other options to go through, and pop health management for them was it. So this is the idea that you'd have a defined budget. So in England, for ICSs, you'd have a defined budget. These integrated care systems, I don't get out much. Integrated care systems, you'd have a defined budget. That hasn't fucking happened. But the idea is that we'd all have more money. And of course, we'd have a defined geographical area, so everyone would be able to be in one place, so we could kind of plan that. That also really hasn't happened, because none of this is coterminous, and that the fact that NHS organisations and all the parts of the system work very, very differently. But the spirit's there. And then, of course, we want to understand health needs and well-being. We'll talk about health, well-being, and the difference from healthcare later on, but this is very important, and identify opportunities to improve it. So basically, this is an analytical approach to making decisions. Who would have thought that a medical care service might use data and evidence to make decisions? Fucking hell, we only did this about 7 years ago. But so we will plan and invest. You know, because we're economists, we want to make sure we put investment in there because I can have a job for a bit longer. Monitor and evaluate, the same fucking thing, but that's good. But important things that we really do care about, reducing health inequalities. Just to remind people, about 52 years ago, Julian Tudor Hart, who went to LSE, he did much better than I did. Julian Tudor Hart wrote a paper about the inverse care law, saying that 52 years ago that health inequalities were rife in the NHS. To remind you, they are worse today than they have ever been. So the wonderful work of Professor Michael Marmot, if you get to see his stuff, has shown how health inequalities have got worse year after year. So even with all of this, we're still not doing as well as we could. COVID was a great reflecting lens on that. But to achieve the triple aim of healthcare, better quality care, better quality experience, and hopefully cheaper in the long run, because we don't have the resources to do this, to improve the long-term health and well-being as we go forward. All makes sense so far. Yeah, defined geography, budget, kind of go from there. Why are we talking about health and well-being? Only 20% of your health outcome comes from the care that the NHS provides. So you've got all of this stuff about your personal behaviours, your physical environment, and your kind of social and economic factors that actually change your outcome. So the chances of having the stroke, the diabetic foot amputation, surviving the stroke, and what do you do with the resources afterwards? All of those things, only 20% comes from what we do in healthcare. And so this is a paper from Hood. And then there's another paper from the WHO who suggests it's a lot less, it's about 10%, but they also include these genetics and biology factors that are involved. So the whole point of looking at health and well-being as population health management, this key thing that the NHS has to do, is about looking at these wider determinants of health that can have a profound difference compared to these marginal gains you can have by changing a drug to make those, say it's a better drug, that's great, but these are wafer-thin gains that you're getting as you kind of go through. All of this was possible, and it's a shame that Simon's raced off, because I'm sure somewhere in there's an index card. But all of this is possible because in the 90s, there's a proliferation of electronic patient records. We now had all this data. So at the end of the 90s, at the beginning of the noughties, if you were a boss, you got invited to see the Pima Indians over in Arizona, or Kaiser Permanente offered you to go over to 1,000 Oaks. I was never fucking invited. Bastards. Anyway, but all of the bosses were there seeing the Pima Indians. And so they're saying, look at the amazing stuff we can do with risk algorithms. We can better understand the patient because we have all of these electronic patient records to help us create these kind of systems to better understand populations. And out of this came two big parts of work: segmentation, and we'll talk about segmentation again. Marketing people and advertisers have been doing this for years, but what do we do for this in health? And also risk stratification tools kind of going forwards. So segmentation, lots of different ways of segmentation, kind of broken down into four. Geodemographic segmentation, this is what our friends in public health are absolutely fantastic at. And by understanding where you live, where you've grown up, where you've been born, we can have a great view on your health outcomes. Why? Because we understand those 80% of your wider determinants of health. Because if you can live in a street, we know, the level of pollution, we know the environment, we know how much money you most probably have to afford the house. To be fair, I live in Stoke Newington. I couldn't afford to buy my house now, and it's only because I'm in my 50s and I moved in when it was cheap that I could afford to live there. But this idea that your life choices and your life options are greatly affected by your geography has been proven because, again, those wider determinants. Audience segmentation is the stuff that our marketing friends do very, very well. This is why Alexa knows that I'm desperate to buy kids' tennis rackets because my son keeps talking about it, and so now I only get adverts for kids' tennis rackets. My daughter started guitar lessons, non-stop adverts for Fender guitars by girls. So it was all female adverts because clearly they overheard my daughter. So audience segmentation, so understanding, but again, a lot of wider determinants data in here. Outcomes-based segmentation, this is the work that I did all the time in hospital. We were looking at unwarranted or inexplicable variation. Why were there so many more diabetic leg amputations in Dalston to Stoke Newington? Why were there so many maternal deaths? Why were there so many strokes? Why were there whatever it may be? And by looking at the variation in those outcomes, we could then try to work out these segments and do something different in them. The problem is nearly all of those outcomes were warranted. The reason why they had those differences is because they were our most deprived populations. Because again, we go back to those wider determinants. Your physical environment, because you're living in a crap house. 1 in 5 dwellings in the UK isn't fit. And so that means they're damp, don't have heat, unsuitable for people to live in. 1 in 5. So some of you may remember in 2023, a young man who had asthma known to the healthcare system being treated for his asthma, had all the right drugs, all the right education about how to take them, rescue steroids. He still died in 2023 in this country because his flat was wet and damp and full of mold. So it wasn't to do with his drugs, it wasn't anything to do with the NHS, it's the fact these wider determinants had effect. So outcome-based segmentation. But what we really want to know is whole population, because the reason being that we need to understand all the well people today, so all you young, fit, healthy people today, when are you going to get sick so we can better plan care? So it sounds a no-brainer that we should be looking at the whole population, but we don't have data on you because the data comes from electronic patient records. And so we only have those interactions when you work with us in the NHS. So you come and see your doctor and you say that you've got your foot fungus or your whatever it may be. How do you kind of then say, well, we've taken these drugs, we've had those things. So we only have records when you interact with the healthcare system. So healthy people kind of disappear. So understanding those wider determinants mean that we can start to fill in those blanks. So what do other 50-year-old men in Stoke Newington who drink too much and play Dungeons and Dragons and all of the other things that we do, what are the outcomes for people like me going forwards when I don't have any connection? Great example, moved to London for university, and I signed up with a GP like everybody else. Didn't see them for 25 years until I had our first child, because I worked with doctors. Doctors wrote the prescriptions. Thanks, friends. And always be nice to the medics. But it's this idea that, and then when we had the kid, we had to sign up. So there's that capitated fee went to this pharmacist, and this GP, who never saw anyone, but no, good for him. But segmentation, a key part. So now we better understand the population. We've kind of put them in a nice little individual segments. And next, risk stratification. So you've got your population at the bottom, and then you've got your y-axis when you're looking at the experience of X over time. So the idea that you spend a lot of time looking at these high-risk people. So again, in the noughties, if you wanted to go to Kaiser Permanente, you said that you were interested in hospital readmissions. Why were we interested in hospital readmissions? Did we give a toss about you? No. If you got readmitted to hospital within 30 days, we didn't get paid. So we wanted to make sure that all those people that we discharged didn't come back. So we did loads of risk algorithms up here to try and identify people at risk of readmission. So some wonderful people that I work with, so Geraint Lewis, Adam Stevenson, Martin Bardsley, John Billings, and people like that created wonderful algorithms. You can now still spend a fortune with Johns Hopkins with ACG, but they created, PAR, patients at risk of readmissions. Again, the NHS, great for naming shit. And then PAR 30, patients at risk of readmissions in 30 days. So what you do is kind of concentrate your resources and everything there. Yeah, that kind of makes sense? Yeah? Oh, good. Good. I'd say, except for the one guy over there who gets it. Yeah, it's a setup. You're right. So 3 quick ways of doing risk stratification. Clinical perspectives. If you've ever worked in a hospital, everyone in A&E tells you who they know is going to come back in. They always know best. They don't. There's loads of studies to show they're shit. But what they do know is that there's some people who do come back in every day, but there's reasons for those small populations doing it. Threshold modelling, the number of events that you're going to have. So people who are over 65 with 2 hospital admissions in the last month, the chances that they're coming in, again, is very, very high. We can kind of model off that. And then, of course, now, if you want a trip abroad and you're a boss, time to go to see the Pima Indians, predictive modelings, fucking don't go anywhere. I got to go to Paddington today to see Microsoft. Paddington. It took me 2 hours to get back on the bus because I can't afford a fucking taxi like those posh knobs. Anyway, so you say that you're interested in predictive models because of AI, and we can talk about, if we have time at the end, causal inference and all those other different ways of doing things. And this is what my PhD is on. But this idea we could do predictive models to best understand those people at the top of the pyramid, those people best at risk. So we have, segmentation, used to highlight population characteristics, risk stratification, used to understand and case find those people most at risk so we can make a difference. It all makes sense. And then we meet this chap. So I told you there was a tie, in this tenuous, shoehorned in way. One, I get to say Slick Willy at work and not get fired. This is Slick Willy. So it's not a gritty STD story, even though it should be now after hearing some of the other things we've heard tonight. So this is William Sutton. William Sutton was a famous bank robber. When the FBI created the first ever most wanted list in March 1950, Slick was on it. He robbed over 100 banks, stole over £2 million in the middle of the Depression, the equivalent of £20 million today. Stole this from banks, £20 million, the equivalent. Supposedly a gentleman thief. He never carried a loaded gun. He often tricked people into giving him the money. He dressed as police, he dressed as security guards. He kind of conned his way in. He was a very charismatic guy. He was caught, and the first time he was caught, he went to East State, Pennsylvania. He escaped by digging a tunnel. This is kind of raw, Shawshank Redemption kind of shit. He digged a tunnel out of his place to the road and made a model with his own hair pulled out in his bed to trick people. He digged his way out. They caught him. They then sent him to, I have got it written down because I forget. Philadelphia County Prison. Philadelphia County Prison. He stole guard uniforms. This famous actor, because he used to dress up. And so he nicked uniforms and walked out of the prison. And they let him walk out. The third time he was caught, he went to Sing Sing. So now he'd got to the maximum security kind of prisons. They don't know how he fucking escaped. He never told them. But he was now escaped 3 times. So on the most wanted list, 2 years later, he was caught. And when he was caught, they said, "Slick, why do you keep robbing banks?" And he said, "Because that's where the money is." Yes? Fucking obvious, yes? They also called him, in America, Robin Hood. But only in America can be called Robin Hood when you steal the money and fucking keep it. There comes to Louise's point earlier, those rich bastards. Anyway, so Slick later denied this. We could talk about the other questions, but we teach medics this today. So this idea that if you hear hoofbeats, think horses, not zebras. If you've ever watched an episode of House, you know that you've got to, it comes something obvious, and then Hugh Laurie spends all his time being grumpy, and you work out, that shows you how old I am. I watched House, and kind of going through. But the problem with Slick is it all seems obvious, yeah? We've done the segmentation. We kind of know what's wrong and what's driving those. We've done the risk strat. We know who's most at risk of having an event. So we should case find. We could find those people with electronic patients, through their records, to identify them to do something different. But the problem is, what feeds those algorithms is electronic patient records, because we don't have all of the data on those wider determinants. So all of those wonderful people I talked about, Geraint, Adam Stevenson, Martin Bardsley, John Billings, all of these people who made these great algorithms, again, you can talk to them today, they're all wonderful people. But they realized about 5 years later that these algorithms were finding people but not changing any outcomes. When I put algorithms fed on EPRs into DALI, awesome. I said, it needs to be cuter. And then I also said, one for you, Alistair, I said NHS sold or paid 350 million to Palantir, the evil spy company, to take its data. And look, even Dali knows that Kaluthu runs Palantir. Anyway, a key bit, so a key part of the work is we can't conflate those most at risk to those who most benefit. They don't naturally go hand in hand, and there's some tests that we have to do to make sure that we're doing it. So, first of all, we may identify someone at risk. How do we stop them? Are the conditions amenable to preventative care? There are lots of conditions that we can identify people at risk where they're very, very difficult for amenable care, and we may not be able to change the interventions to change the outcome that's going forwards. One of the reasons they may be at the top of the kind of risk model is because we have so much data on them, because we're already doing everything we possibly can to help them. They've had all the diagnostic tests, they've had all of the drugs, they've had all of those bits. So doing more creates a triple fail event where we do too much for the patient, they have a poor experience, and they have no worse outcome, or potentially they have a worse outcome because of the harms of all the things that we're doing to them that kind of go forwards. So we can do a gap analysis to make sure Slick isn't tricking us as we go forwards. Behavioral response models. Are you likely to respond to the intervention, this new intervention, this thing that we're going to do to change your outcome? Are you likely to respond to that? And if you're not, what intervention can we offer you that you would respond to? Propensity to succeed models. And again, this is where there's some bias put in. What's your likelihood of succeeding on these? So if you've got a family to support you, if you've got the personal resources, again, this goes to those wider determinants, your social and economic circumstances and your personal behaviors. It can make a big difference. And finally, healthcare professionals still have a role to play. And again, lots of it is filling in the data gaps that we don't have in EPRs with those wider determinants. A really, really quick run through, I promise. So also there's the fact of regression to the mean. So here's a study we did as part of the new care models at NHS England. We've taken the names off. You say I don't get told off by anyone in NHS England. So this is one of the things we did in new care models, was try lots of different approaches to how we delivered care. And we were very well funded for a period of time, and it was a wonderful kind of joyous place. And then NHS England moved the goalposts and said, the only outcome we're interested in is hospital admissions, because we're obsessed with hospital admissions. So this is our test group, and because we're really good at the maths, we did a propensity score matched cohort to match those, and we're really, really chuffed. Look how fucking good the maths is there, guys. Look at that. And then, of course, we had the intervention. Yes! The intervention works. People stop coming into hospital. They don't readmit in the time. Everything's working fantastic. This is fucking brilliant, yes? Then we look at the control group. Bollocks! They do even better. And so in the fact that these groups, because we've entertained them and spoken to them, they come back more than the other people. And it just shows you that this idea that regression to the mean, you spend very little time at the top of the risk pyramid. Either you get better and move back down the pyramid, you die, or the event happens, yeah? And the thing, you can't stop it. And there's a very small proportion who stay at the top of a risk pyramid where you can try and intervene. So impactability, this idea that what we try to do is find people who are amenable to different interventions based on those wider determinants, not just your health records, to find where you may, within that risk model, kind of go from there. So when you start doing your population health management and you're doing your segmentation and risk stratification, I urge you to kick the tires to make sure that Slick Willy isn't robbing you and making you do the wrong thing. Dali, what does it look like when a data scientist catches Slick Willy? Look. How fucking handsome is he? I want to date him. But anyway, so just to say, impactability modeling is now the third step. I then said, can you make that data scientist an NHS data scientist? But this is what real data scientists and health economists look like in the NHS. A wonderful bunch of people who are doing their best to work with you on those risk algorithms to be able to try and better identify people who will be amenable to change. Thank you. Oh, questions. And a shameless plug at the end for someone, if you can remind me, Alistair.
Can you just run through it again?
I'm knackered. Yes, sir.
Are you anything to do with the NHS Future Health study?
No, but Adam Stevenson.
Sorry.
Oh, sorry. Am I part of the Future Health study? So this is a wonderful study. Adam Stevenson, who is the director of analytics at the Health Foundation, a wonderful think tank that does a load of work. It's now over, I believe, at Future. So this is one where they're trying to collect all of your data to be able to help provide predictive models going forwards, going from there. So no, but it's a noble cause, and we spend and share some time and speak to them.
Because it's healthy people, not just sick people.
Yes, and again, it's this, so to be clear, some of those names I mentioned, when I started my PhD, and Adam and Geraint, who's the kind of father of impactability, this horrible American word, because he worked for Walmart for a bit of time for his Harkness Fellowship. When he kind of came back, he just said, I want to do my PhD in this, I've been talking about it. He just goes, you're not going to fucking maths your way out of this. And because it's not a maths problem, it's this wider determinants problem. There's not more data. However accurate the models become, we still have this missing bit around making it meaningful or impactful. We're great at guessing that you're going to be ill, really bad at changing the outcome. Sir.
Yeah, I'm going to sound really libertarian here, and I promise I'm not. But it seems like a lot of the studies come out of America because health insurance companies want more money. And it's very easy to say, if you can stop people getting readmitted to hospital, we'll give you more money.
Yeah.
So do you think that there is a role to play for essentially private healthcare and non-publicly funded healthcare and getting these outcomes?
So the role of private insurance companies in the promotion of health and making things better by building these algorithms, the fact that impactability came from the insurance companies. So I'm the tofu-eating wokarati in fucking Stoke Newington, so no, they're all fucking evil. And I'll explain why. They're not doing this to identify health inequalities. We look at these people and we go back and try to find people who are most at risk. And so we spend a lot of time and we kind of go, well, all these people up here are very expensive. The top 5% of that pyramid where we talk about costs about 50% of all of your resources in whatever you're looking at. So we'll look at these people here, and what insurance companies do is go, fuck them. They're too expensive. How do we price them out of the pool? And so through, as an economist, and no, we spend a lot of time with actuaries, my dad was an actuary, that's how fucking nerdy our family are, is the fact that they spend a lot of time looking at these bunch, and because what they need to do is price them out of the pool because they can't afford them. So there's lots of things that they do around looking at gaps in care. If you have no gaps in care and you're still at risk, you've got to go. Yeah? You speak Spanish, and you've got hypertension, well, that costs a lot more because we have to do leaflets in Spanish or have someone who speaks Spanish. You can jog on. So there's loads of examples. The famous one about them doing the tea dances, if you've ever heard this, come to a tea dance. If you come to the tea dance, we'll insure you for free. And so what they did was invite all these old people. They put it on the 4th or 5th floor of a building. They turn the lifts off, and you have to walk up the lifts. And so if you can walk up 4 floors and dance all evening, they would insure you. And I'm not fucking making this stuff up. This really happened, yeah? And so this is the way of them creaming. So cream skimming, you'll have heard it. And so, yes, they do have a very good role to play. And just to say that integrated care systems that we're doing now, so my work in the World Bank, Central and Eastern Europe are using exactly the same approaches, but for very different reasons, I feel. And but and if you work for an insurance company, I'm really, really sorry. I love you, and you're and you've got at least 3 or 4 friends. So I'm going to beat the shit out of. So I'm going to run anyway. Sorry. Anybody else? Yes, miss.
As far as I'm aware, the NHS is considering rolling out genetic, whole genome screening on newborns. I was wondering how you think that might affect your risk profiling in the future.
So I was. I said I wasn't joking. I really was invited. Oh, sorry. So looking at whole genome, taking people's whole genomes when they're on the ward, so we can better understand the risk. As you say, your genetics and your biology play a huge part kind of going forwards. And the 100,000 Genome Project has been very, very successful. We've done that. But I think it will have a role to play when things like CRISPR we can have a much quicker turnaround on saying how we would edit genes to be able to make a difference in those kind of people. And again, I don't know enough about these kind of genetic medicines that you can do to change those kind of bits. But at the moment, if you have a propensity to gain weight or to have heart disease or to whatever it may be because of your genes, it's very, very difficult to make those changes. But I'm guessing the second that we can start changing those, or the drugs that kind of can target those better, it would be a real, again, a significant game changer. But still only 20% compared to your personal behaviours and your environment, which play about half of everything. And thank you, sir.
What's your favourite health economics graph?
What's my favourite health economics graph? So again, I'm a huge fan. So the reason I got into health economics was it was all to do with inequality. So I was a statistician by training. I saw them. So it's Julian Tudor Hart's stuff about the inverse care law. And for those of you who know, it basically means that there's more care where it's needed the least. So great big hospitals, especially the lovely rich hospitals that have funding from research and beyond, and academic hospitals get much, much more care when they're needed. And then you go to an estate and they may not have any good access, or some rural places, no good access to hospitals. No researchers want to live in the middle of nowhere, and so you don't get the care. We spend a lot of time in Sweden with the World Bank trying to attract staff, so they also have a workforce issue, and they can't get staff to work outside of the major cities. And so they're now trying to adopt really advanced kind of digital techniques or others to invite people, to get people really excited about working there. So you could do remote telemonitoring with Bluetooth stethoscopes, and there's these new apps that can take your blood pressure by looking at your face. All of these kind of out there kind of things to attract doctors to go to these rural places. But for me, it's always the inverse care law and some of the Marmot stuff. If you've seen the plateauing of life expectancy, I think is a real stark reminder of where we are today. And again, 11 years life difference or life expectancy between our richest population and our poorest. Our poorest population of women live a third of their lives with disease. Sorry. Yes, miss.
Thank you so much. It was really great. I work in mental health and readmissions in inpatient care, and I told my colleagues that I was coming to this tonight to learn about what we can learn So can you just like tell me like 2 sentences like what we can learn from
This is 5 years of my life of a PhD, summed into 2 years. Thanks. No, to be fair, if you're not clever enough to explain it quickly, you're not clever enough to. So I think that the key bit is that we're great at identifying people at risk. We're really bad at stopping or changing the outcome. So it's one of these kind of sci-fi dystopian things. You know the person's going to be murdered, but you can't stop the murder happening, whatever it may be. So if it's mental health readmissions, you've got wonderful. To be fair, mental health, you've got shit data. But in mental health, it's you know the person's going to relapse. You know that they may be sectioned. You know that they may have an event that means that they're in A&E, causing great distress to them and others. But you just can't stop it. So it's about better understanding what those people are amenable to. How can you make the change that will stick? Because what we often do is provide interventions on a bell-shaped curve, because they've got to be economic. We've got to try and do the 80% that works for most people. But of course, it's these outliers, these people with the highest deprivation or with some very complex problems that we need to tailor things. It costs more to be able to do that, but of course, it's the right thing to do to change outcomes. Sorry, it's not 2 sentences. I'll try better, miss. Sorry.
Okay, so this is the last question. Make it good. If you're not confident that it's good.
Very, very suspiciously, I'll choose an NHS colleague from the back. So, Miss, I very much look forward to your very easy and lovely question in return for a drink.
So I was going to say, how much do you think is the risk of the poor quality of data? So all these models and all this clever work we do is based on Sandra, who's underfunded, band 2, putting the work data in, and or it not being on a piece of paper that's still everywhere.
Yeah.
What do you think the risks are there?
So what do we do about data quality and improving data quality so we can make the best possible decisions? So the best way to improve data quality, and there's loads of work on this, is to actually use the data. And then the people who are collecting it, if they see how it's used, data quality improves very, very, very quickly going from there. So absolutely, there are loads of people who are clinical coders, the band 2s, 3s, 4s, 5s who are doing a whole load of work and putting this information in. It becomes very, very challenging when you don't see why it adds value, and then when you can see it being used at the other end, it's great. Also, we're much better now at imputation and kind of putting in the right kind of data when we have data blocks and or gaps in data. And so again, we always have this wonderful catch of getting the healthcare professionals to make sure that if we are making decisions, so many of you would have heard about the people as part of shielding. We're trying to work out how tall people are. We record this in centimeters. Some people were 1.79 centimeters tall because they thought it was in meters. Some people were 1,790 centimeters, and all of these things. But there's ways now that we can use, and again, for these predictive models, to say, do you really think it could be this? We will put this in and put a flag on it saying this is calculated with this imputation. So kind of going from there. So, but again, all data, unless people can see the value, it's always going to be crap. My very last thing, because I'm a 50-year-old man, I'm in a dad band, and we're playing a gig. It's an NHS band, and if you want to come and see the HEUristics, because again, we're shit at naming things. Health Economics Unit, we thought we were so clever. But we have a gig if you guys want to come in Hoxton, if you want to see, some of them are much younger than me, playing 80s and 90s rock. Thank you.